Hey everyone, Chris Brown here. I'm fortunate enough to be joined by Jason Wollmuth, the director of the Complex Coronary and Interventions program at Providence, Portland, and St. Vincent Heart Institutes. He's going to give us a couple of lectures today, first about single access and second about a new technique for closure with large bore devices. Jason, how's it going? Thanks for joining us.
Good. Hey, thanks, Chris. Thanks for inviting me to be a part of this. It's great to see you and great to be with you. So Chris, first off, we're going to talk a little bit about single access. This has kind of become a fairly commonplace way to do high-risk PCI with Impella support nowadays. But we're going to kind of review some of the original stuff that we worked with, but also talk a little bit about the development of the companion sheath that Abiomed brought out with the help of Merit over the last year that has kind of simplified this a little bit. So single access is a technique for placing a sheath and a guide for the PCI through the Impella sheath for protected PCI. And the value of this is really that it minimizes the risk of additional access, but it's also a great option in these patients oftentimes who have limited access options. You can kind of minimize it by limiting the access to one spot, but it's also great for preserving additional access sites for secondary guides, particularly for CTO PCI. And it can be compatible with both 6 and 7 French sheaths, but also we've developed a way of using a sheathless 8 French guide for those rare cases where you would need an 8 French as well. This has kind of become very, very commonplace. The most recent data that I saw is up around 70% of cases using Impella for high-risk PCI have been using the single access technique. Myself and a couple of colleagues published our initial experience with this in 2019, and within a year, over 40% of cases in the U.S. were being done with single access. And so the idea is that arterial access is gained through the 14 French Impella CP sheath, and it can be used with either the long or the short sheath. And access is gained through the diaphragm simply by using a needle, either a micropuncture needle or an 18-gauge access needle, to allow placement of an 035 wire through the diaphragm that you'll be able to place a secondary sheath through.
Jason, maybe it's in the next slide, or maybe we should talk about it here, but can you tell us about the best position to make that puncture? Because as you mentioned, you're trying to avoid that diaphragm, the little slit where the Impella goes through, but you need enough space to get your other stuff in, I presume. So where's the best place to do this? Is it up at that picture where you pointed at 2 o'clock? How far from the edge to the diaphragm? What's the best way to go about this?
Yeah, so if you can see kind of in the upper right-hand part of my screen, the little X in the middle with those 2 lines coming from it are the preformed slits in the diaphragm, because again, this is a peel away sheath. And so that's where the peel away happens. And so I try to avoid that area. If you get a little close to it, sometimes you can have some disruption of that and have a little bit of bleeding. It's usually not a big deal if you do have that. You just pull out and re-stick. But I kind of go up around 2 o'clock as shown in the site or on the slide. And you want to be a little bit careful that you're not real close to the shaft of the Impella and potentially sticking the Impella shaft. I don't think I've ever had that happen, but theoretically it could. But you also don't want to be too close to the rim of the sheath, because there is a little plastic on the back side. And sometimes when you stick through, you'll feel some hard plastic. And if that's the case, you need to go a little closer towards the shaft. So I go about halfway between the rim of the sheath and the Impella shaft. This kind of shows the single access technique. This is an axillary case I did a number of years ago. And you can see that I'm kind of using a micropuncture needle, same needle that I used for my original access. And again, kind of just puncturing through the diaphragm. You don't need to pass it very far. You certainly don't want to push it all the way down and potentially run the risk of hitting the Impella shaft. I like to use the micropuncture needle just because that's what I usually have on the table. And so then we'll switch out for an 035 wire. I typically just use the Amplatz wire that comes with the Impella kit, just because it's nice and gives you a lot of body while you're advancing your sheath. When we first started doing this, we would dilate the sheath, but there's really no need to do that anymore. And here you can see that I'm then passing this is a 45 centimeter pinnacle destination sheath. Now, one of the things that I was doing here that I or not doing here that I do now is, as I'm advancing the sheath, I wasn't holding the shaft of the Impella, and that has kind of come to light as an important thing to do to avoid the risk of advancing the Impella inadvertently.
So that's a good
So
point that we should emphasize, that the way you do that, you hold it the way you would hold a wire if you were advancing a balloon over a monorail, sort of same exact fashion, or how do you do it?
Exactly. Yeah. Hold it with my left hand, push the sheath with my right hand.
Awesome.
So, there's a number of sheaths that I've tried over the years, but I kind of fell into the two at the top of this list as kind of my preferred options. I pretty much was using mostly the 45 centimeter Pinnacle Destination sheath. That has 35 centimeters of coating on it, so it's easy to slide in, except for the last 10 centimeters, which can be fairly difficult to get through because it's not coated. And you can see on the picture what that leaves you with is about 10 centimeters of the sheath hanging out through the Impella sheath. Not a big deal for most patients, but if you have a tall patient or you have a patient that has a lot of aortic and iliac tortuosity, the issue with that is sometimes you couldn't get a guide to reach the coronary. And so in those cases, I've been using the Merit radial slender sheath. It's a radial sheath, but it's a braided sheath, and so you're able to advance that all the way in, and it does give you good support. Standard sheaths I've used, it seems sometimes I would have some difficulty with guide manipulation over the course of the case, but overall those work pretty well. In addition, the ones that I haven't had success with are the Terumo slender sheath because it just doesn't have enough radial strength. And then the bright tip sheath, I have a hard time getting the tip through the Impella sheath. And then the Cook and Raby sheaths just don't have enough hydrophilic coating on them, and too much of it hangs out of the body. It seems like the longer sheaths have less interaction with the Impella shaft, so that's why I tend to use the 45 centimeter sheath, or at least historically have.
Yeah. So do you think you got to clear the peel away that you're using with the sheath that you put in to really not have the guide have interaction with the Impella shaft? Is that sort of the
it's hard to
short one, the short one?
I think in a lot of patients it makes no difference at all. But I think in folks where potentially there's a lot of tortuosity in the iliac system, potentially, I think the longer sheath may kind of straighten that out a little bit, and then again minimize the amount of interaction. And so that's why I've kind of favored using a longer sheath. I haven't really, again, you kind of fall into the thing that works for you. And so I tend to use mostly the 45. So I think I may not have as much experience with shorter sheaths, but it's one thing that I think has come up as potentially advantageous of using a longer sheath. And in that light, Abiomed came out with the new companion sheath over the last year, which is a specifically designed single access sheath made with Merit Medical. And it's a 7 French sheath, and it's hydrophilic over the entire length of the sheath, which is nice because then you can hub that sheath up to the Impella sheath. And it's braided, so it has a lot of radial strength, so you don't have a lot of interaction with your guide once it's in. It's also a longer sheath. It's 30 centimeters, so you're not going to get much interaction with the Impella sheath, whether you use the long sheath or the short sheath. You can completely get the sheath in, and there's limited resistance while you're pushing it in. I remember the first time I used it, it went in so easily and so smoothly. I said, well, why isn't this in an 8 French? Because it just seemed like if that goes that easily, why wouldn't an 8 French come in?
I agree with you completely. It just slides right through there. All the other ones kind of had a little bit of resistance here and there, the last 10 centimeters for sure in that destination. But this thing is so good. It does make you wonder.
Yeah. So one of the things that has kind of come to light, though, since it's been out, is that the hemostasis valve adapter that you screw onto the back end of the sheath, it comes out of the package already attached. But you can unscrew that and take it off. And some people, and they've had some issues where people over tighten that valve adapter onto the sheath, and it can actually break and can become loose. If that were to happen, I don't think it would be much of an issue if you have a 7 French guide in. But if you had a smaller guide in, a 6 French guide in, potentially you could have some bleeding around there. Again, probably wouldn't be a big deal if it happened. You could pull everything out and restick, but it's something to be mindful of. And so now they're instructing people just to be careful and not over tighten that when you
That's
take it out of the package.
That's a really good point. So a lot of times these sheaths come with those things not tightened. When you get your destination or
Yeah.
whatever, it's like halfway on there or halfway not on there or whatever. So it's good that we all know that you're not supposed to really crank down on it anymore. It's already actually been put on correctly.
Yeah, yeah. This is a nice slide that kind of compares it to some of the other sheaths that we've been using, and some of the things that I think to highlight is just that the outer diameter is quite small. It's not as small as a couple of the other ones like the Merit radial sheath, which is a little smaller. It is this small, a little bit bigger than the Terumo sheath, but again, I don't use the Terumo sheath just because it doesn't have enough radial strength. And so, it really has the smallest outer diameter of any of the things that we mostly have been using. And it's hydrophilic coated again throughout the whole length of the sheath, which again makes it very, very easy to get in. And again, like I said earlier, it's braided, which makes it have a lot of durability and radial force to stay open and give you the maximum amount of guide manipulation throughout the case. There is a way to get an 8 French sheath in without excuse me, an 8 French guide in without a sheath. It's a thing that I kind of worked with Stefan Renfray to develop, and we published this a couple of years ago. You basically take your 8 French sheath and you use a dilator from 110 centimeter Cook flexor sheath, which we have a picture of over on the right. And you use that as a dilator to get the sheath in. And the way we do it is we actually will flush the Impella sheath with either Rotaflush or Viper Slide just to kind of coat it. And then we do routine single access to get an 035 wire in. And then we actually dilate the tract or the hole through the Impella diaphragm with one of the Impella dilators that come with the Impella. Those are really nice because they actually leave some coating, which allows for a smoother passage. And then you pass the flexor dilator with the guide as a unit up through the sheath. The one thing I have found in doing this is over the course of the case, you start to lose the ability to manipulate the guide a little bit. Things start to become a little stuck. And so I have reflushed my sheath with Rotaflush or Viper Slide, and that seems to help. But it can be a bit of a challenge. Like if you're doing the times I tend to use an 8 French sheath is like if you got a left main trifurcation and you're going to need a lot of gear, or it's a retrograde case where you want to use that as your antegrade guide, where you really want the bigger size. Oftentimes those are cases where you're having to work right at the ostium of the vessel, and you're doing a lot of in and out and moving the guide. And that becomes a little bit troublesome by the end of the case. So just one thing to be mindful of if you try to use the 8 French sheath.
Gives us a good chance to call out other companies who make hydrophilically coated guides, make us an 8 French guide. There's a 7.5 French UCath, but that's the biggest one that I know of. So somebody out there needs to make an 8 French for us.
Yeah, and I don't have the OCaths, but my friend Kevin Kroos has used them, and the 7.5 will fit, and theoretically, I believe the 8.5 should fit as well. But again, I don't have those, so I don't have any experience with them. But I know there are operators who have used those, and it's a nice. If you're comfortable with those guides and you have those guides, it's a nice way to use it and get to really maximize the amount of room that you have for delivering extra gear.
They're pretty stiff at the tip. They're I don't want to say dangerous, because dangerous is the wrong word, but you have to be very thoughtful with them. They're a very particular guide. We have them and we use them a good bit, but they're very unique.
Yeah, and I've heard that you can't see the tip as well. Is that right?
Yeah, because so what happens is you can't see the dilator. So you can see the tip of the guide because it has a radio marker on it, but the dilator, which extends out from it, you can't see it. So you have to use both your intuition as to where that tip is, as to where you think the dilator is, and then how the wire is interacting, so you can pull the dilator back and slide the guide into position. They're also a little bit hard to straighten back out. So if the, you know, the extra backup version of that guide is folded on itself, unfolding it is not so easy. You need the back end of a wire or an Amplatz that has a 1 centimeter tip because it doesn't want to unfold. It's very stiff. It's a very powerful guide. But anyway.
Good. Well, I'll have to get them and get some experience. So
yeah, give it a try.
Yeah. You know, obviously there's concern of complications with anything we do, and this has some potential complications. This is an unfortunate case I heard of a number of years ago where they didn't do what we talked about earlier, where we hold the shaft of the Impella while advancing the sheath in. And in this unfortunate case, the Impella actually was pushed out through the ventricle, and the patient had to go to the operating room. Bleeding from the diaphragm can happen. I've had this happen a handful of times. Usually when I put my sheath in, I just kind of watch it for a second or two just to make sure I'm not seeing, you know, blood kind of oozing out. But if you see that, it's really no big deal. You just remove everything and re-stick in a different place. One of my partners did have an episode one time where he had some bleeding around the sheath after he put the PCI sheath in. We weren't sure if it just caused some kind of you know, deformation of the Impella sheath through the arteriotomy, or exactly how that happened, but we just tightened the per-close suture that he had pre-placed, and that seemed to solve it. I've never really had this issue myself, and I don't know if others have, but I do know that is a potential issue. A lot of people are concerned about disrupting the sheath or tearing the peel away sheath. That could be a bit of a problem. If that happened, obviously you'd have to take the whole thing out and either introduce the repositioning sheath or take the entire Impella out and use the second sheath in the kit. Again, I've never heard of that happening, but it's always a theoretical risk. There is a concern, and I think this is probably one of the main reasons why some colleagues are not as enthusiastic about using it, is the lack of second access to manage a complication. We have some things that we've done to kind of try to mitigate that a little bit, but again, it is a potential issue. And then again, movement of the Impella while advancing the sheath, it's important to fix the shaft.
And Jason, can we go through that a little bit? That lack of a second access, you know, you have one access regardless of where you put your sheath, if it's through the Impella or through a other artery, wrist or femoral or whatever. And then of course, if you need a second access to manage a complication, you have to obtain it. So what's the main concern that people have with that?
Well, I think, you know, there's a lot of folks, you know, for example, a good friend of mine, Amir Kaki, he does a completion angiogram for every single case he does, which, you know, I think is absolutely amazing, you know, because he's very, very attentive, and, you know, his risk of vascular complications is going to be exceedingly low because he has such meticulous technique. And so you don't have that access to do a completion angiogram necessarily. And so, you know, if you're really concerned about the access site itself, so say when you're using your ultrasound, you've got a lot of atherosclerotic disease or calcification of that common femoral artery, or once you get access, you have difficulty getting good per-close sutures in, you know, 2 or 3 of them fail. Those are the ones that I always worry about. I always think those are the highest risk of having a poor closure. And so in those cases, I'll oftentimes do kind of a single access dry closure, or I will actually get a second access for a completion angiogram and be ready to manage that complication. The last thing you can do is there is a way to do a single access completion angiogram where you, after you take your sheath out, obviously you're leaving a wire in. Sometimes you can actually just put like a 4 French sheath over that wire and then close over that 4 French sheath. Obviously you don't tighten the knots on the per-close, you just push them down to the sheath. And then you can actually take a picture through that 4 French sheath. And if everything looks good on that 4 French sheath, you're going to be probably pretty good by pulling that out. You know, essentially the worst case scenario is you're holding a 4 French arteriotomy hole.
And we have a video on that. That's how I close all of our Impella access cases, is we use, as a peripheral vascular operator, I'm with you on the the attention to the vascular detail. So we close everything over a 4 French sheath, and we use a 4 French omni or pigtail and take completion angiograms in every case. When we have a video, actually, for everybody watching on Murmur, you can watch it. Shows how we do it. But that's sort of how we got over that second access thing. But I think it's really important that everybody thinks about that and that we went through that there, because you're right. You do need another access if you need to go up and over, or you need to really repair the artery, and that's important to remember. So.
Yeah, I think the biggest challenge in these ones is the patients that don't have contralateral common femoral artery option, because then you're having to go, from the arm usually to deliver gear, and again, there's balloons that we can get down there, but then if you needed something like a covered stent, then you're in a bit of trouble getting it there. So we use single access obviously for getting the PCI guide in, but I've actually used it for some other issues that have kind of come up during complex PCI. This is a case where we had difficulty delivering the Impella around a diseased kind of iliac bifurcation. You can see it's always the outlet that kind of gets caught up. It seems like when we're delivering Impellas. And so we ended up using single access and getting a second wire in. We actually put like a Lunderquist wire, and it kind of straightened everything out and allowed it to not have that buckling that you see on the left, and allowed us to get the sheath around that tricky bend.
It's great little buddy wire. I like that trick. That's really nice.
Here's a case where you can see the aorta is small and calcified, and hate to see what's on the inside of that thing and what I'm dragging along the way, but you can see the Impella is getting caught delivering through that. We tried buddy wiring it, and it didn't work. And in this case, we ended up placing a balloon over a second wire and did a balloon inflation, and kind of almost like did a balloon assisted tracking to get it around whatever that spicule of calcium was that was obstructing our Impella delivery. Here's a case. I've done this a couple times. I tend not to do BAVs hardly at all anymore, just because most of the time you don't need it to get an Impella through unless the valve area is really, really small, usually less than 0.6. But here was a case, the valve area wasn't terrible, but there was just some chunk of calcium that was preventing me from getting my Impella through. So we did single access, got a second wire through the aortic valve, and then through over the wire, we were able to then deliver a 14 by 40, I think this is a Armada balloon, just a big peripheral balloon. Kind of did a mini balloon valvuloplasty, and then kind of did basically it's similar to what we did in the aorta on the last one, like a balloon assisted tracking to get it through. So, again, these are things that we've all encountered over the years. Delivering Impellas sometimes can have challenges, and utilizing the single access technique to kind of overcome it by some of these things can be helpful. This is the single access dry closure. So this is a case where I'll do this occasionally in cases where I'm really concerned about my closure. Oftentimes those are the cases where you've gone through 2 or 3 failed per closes before you finally get 1 or 2 to catch. So what I'll do is I'll position, you pre-close obviously the arteriotomy, you position a peripheral balloon that's size 1-to-1 to the external iliac artery and do a low pressure inflation to 2 to 4 atmospheres. You then remove the sheath, you pull down the knots to the arteriotomy, but you don't lock them. You then deflate the balloon and check for bleeding. You can do a balloon injection or an injection through the balloon wire port if you need to, similar to what we talked about with like putting in a 4 French sheath. And usually at that time, if there's adequate hemostasis, occasionally you'll get a little bit of oozing, but that's usually not much at all. Then you can pull the balloon and then tighten and cut the sutures after you pull the wire. If there's ongoing bleeding, you remove the balloon, leave the wire in, and deploy an additional closure device. And in those cases, I oftentimes will put in a a 6 French angio seal as kind of my final closure device. And this basically what this does is it kind of buys you a little bit of time. So if you do have a fairly catastrophic issue at the artery, you can at least leave the balloon inflated proximally. It's still going to bleed, but it's easier to control the artery with that, because you can take the aortic pressure off of it. And so basically you're holding pressure against back pressure, coming up the artery. So it just buys you time if you need to, get another access to get in to gain control of the artery.
And for some of our younger operators who watch our videos, this is an over-the-wire balloon. There's a lot of rapid exchange balloons built now for peripheral space. Don't use those. There's no way to inject through those, obviously. So
yeah, and peripheral balloons usually come in 80 centimeter or 130 centimeter lengths. You want to use the shorter ones. They're a lot easier than the long ones. So, and again, this is just kind of a picture of a completion angiogram. You can either close over a 4 French sheath, or also sometimes we'll use the micropuncture sheath that can't get this to play here. Oh, well, so we put a 4 French sheath in. You close over the 4 French sheath, again, not locking the sutures, but then you can do a completion angiogram to get a look and see if there's any concerning extravasation before you lose wire position. So that's what I've got for single access.
That was great. Thank you so much for that, Jason. And we have tons of tips and tricks there, and that's some really good stuff, and especially unique tricks for people to use with that sort of balloon side-by-side balloon assisted tracking technique. That's I think that's going to be new for a lot of people, and I think that's going to help them with their delivery of stuff. So thank you for coming, and thanks for doing this.
Sure, you bet. It's great joining you, Chris.